Okay, let's unpack this. You've shared some really um, comprehensive notes on septic arthritis with us.
Yes, definitely a key topic.
Right. So our mission in this deep dive is basically to take all that detail and turn it into a clear, concise, and well, hopefully memorable understanding of the condition.
Like a high-yield revision session.
Exactly. Your own personal session will cover, everything from what it actually is right through to management. We'll really focus on the practical points, maybe some memory aids to help it all stick. Ready to dive in.
Absolutely. Let's do it. Getting this right is so important for patient outcomes.
Okay, so starting right at the beginning,
Yeah.
what is septic arthritis?
Well, fundamentally, it's an infection inside a joint space.
Right, and your notes highlight it's not just like a minor irritation. It's caused by actual microorganisms, bacteria mostly, but viruses, fungi too,
That's correct. They invade the joint space, and that kicks off inflammation.
which leads to that classic painful swelling, difficulty moving the joint.
Exactly. And the really crucial part, as your notes stress, is that if it's not treated quickly and effectively, you can get significant joint damage, serious damage, and even systemic problems spreading through the body.
So it's an emergency, basically.
Pretty much. Your notes mention acute and chronic forms, but the acute form definitely demands rapid diagnosis and treatment. You've got to preserve that joint function.
Okay, to help remember the basics, maybe think SIJ, swelling, infection, joint pain.
A simple, but captures the core features. SIJ. I like it.
Good. So let's dig into the why, then, the etiology. Your notes point to bacteria being the main culprit, right? Staphylococcus aureus comes up a lot.
Yeah, Staph aureus is definitely the most common bacterial cause we see. But as you said, it's not just bacteria. Viruses, fungi, even mycobacteria can be involved sometimes.
And why is it important to remember those less common causes?
Oh, if your initial treatment, the one targeting the usual bacteria, isn't working, or maybe the clinical picture looks a bit unusual, that's when you start thinking about those other possibilities.
Right, expands the differential. So how do these bugs actually get in? Your notes list 3 main ways.
Three main routes. First is direct entry, think joint surgery, maybe an injection directly into the joint or even trauma.
Okay.
Second is hematogenous spread. That's where bacteria travel through the bloodstream from an infection somewhere else in the body, like a skin infection, an abscess, UTI.
Got it. Travels through the blood. And the third?
Contiguous spread. That's infection spreading from tissues right next to the joint, like an overlying skin infection or osteomyelitis in the adjacent bone.
Makes sense. And your notes specifically flag up Neisseria gonorrhea.
Ah, yes. Very important in typically younger sexually active adults. If they present with septic arthritis symptoms, especially involving maybe wrists, ankles, or knees, you absolutely have to consider gonococcal infection.
Okay, so let's put that into practice. Imagine a young sexually active patient presents hot, swollen knee. What organism jumps to mind early on?
Neisseria gonorrhea. Definitely high on the list. It guides your specific tests, like swabs from relevant sites and your initial antibiotic choice.
Good example. Now, who's more likely to get this? Risk factors. Your notes have a pretty comprehensive list.
Yeah, there are several key groups. Increasing age is one. Diabetes mellitus is another big one.
And pre-existing joint problems like RA or gout.
Exactly. Rheumatoid arthritis, gout, pseudogout, any condition that's already damaged the joint structure makes it more vulnerable. Osteoarthritis, too.
What about surgery?
Oh, definitely. Joint surgery, especially having a hip or knee replacement of prosthesis, is a major risk factor.
Your notes really emphasize having a skin infection at the same time as having a joint prosthesis. Why is that combination so risky?
Well, it's a potential direct route, isn't it? The skin infection provides a source of bacteria close to the implant, and bacteria just love to colonize foreign material like a prosthesis. It can lead to a really deep-seated, difficult infection.
Okay. And finally, immunodeficiency is mentioned, like with HIV.
Right. Anything that weakens the immune system makes it harder for the body to fight off infections, including one trying to establish itself in a joint.
Okay, lots to remember there. Let's try a mnemonic from your notes. A DJ ships.
Let's see. Age, diabetes, joint damage, surgery, hip knee prosthesis, immunodeficiency, skin infection, plus prosthesis.
A DJ shipped us. Hopefully that helps it stick. Right, let's get into the pathophysiology. So the microbes get in, and then what happens?
So they invade the joint, and the body reacts. The synovial membrane, the lining of the joint, gets inflamed, very inflamed.
Synovitis.
Exactly. And this inflammation leads to fluid pouring into the joint space. That's your effusion, the swelling you see and feel.
And it's not just fluid, is it? There are inflammatory cells in there, too.
Oh, yes. Neutrophils rush in trying to fight the infection. But this whole process, the bacterial toxins and the body's own inflammatory response, unfortunately, starts to damage the joint tissues,
Which tissues specifically?
primarily the articular cartilage. It gets degraded by enzymes released by both the bacteria and the inflammatory cells. If it goes on long enough, the underlying bone can also be affected.
That's why treatment needs to be fast to prevent that irreversible damage.
Precisely. And something interesting your notes highlighted, even though Staph aureus is common, the main way it gets in, particularly in adults, is often hematogenous spread from somewhere else.
Yeah, that stood out. And the knee is the most common joint affected in adults.
Right. So the implication is if you see a septic knee, you need to think, okay, where might this have come from? Look for skin lesions. Check for other potential infection sources elsewhere in the body. Don't just focus on the knee.
That's a really practical point, which brings us to differential diagnosis. It's not always septic arthritis, right? What else could cause a hot, swollen joint?
Oh, absolutely. The list is quite long. You've got your primary rheumatological conditions like a flare of rheumatoid arthritis, or even osteoarthritis can sometimes present acutely. Vasculitis can affect joints too.
And the crystal arthropathies.
Definitely. Gout and pseudogout are classic mimics. They cause intense inflammation, redness, swelling, looks very much like infection. Analyzing the joint fluid for crystals is key there.
What else? Your notes mentioned quite a few others.
Yeah, things like drug-induced arthritis, reactive arthritis, which can follow certain infections like gut or genitourinary infections, Lyme disease, viral arthritis, even infective endocarditis, an infection on the heart valves, can sometimes present with joint pain.
Wow. Okay, so it's crucial to differentiate septic arthritis from all these.
Absolutely critical, because the treatments are totally different. Giving steroids for what you think is gout when it's actually septic arthritis could be disastrous. You need antibiotics, and quickly.
So the message is, think broadly. Inflammatory conditions, infections elsewhere, crystals, even drug reactions. Keep an open mind initially.
Exactly. Use the history, the pattern of joint involvement, risk factors, and investigations to narrow it down.
Okay. Let's look at the numbers epidemiology in the UK. Your notes say it affects all ages, but is more common in those with existing joint disease or immunosuppression.
Which fits perfectly with the risk factors we just talked about.
Makes sense. And Staph aureus is still the top bug overall.
Still number one.
Your notes give specific figures for disseminated gonococcal infection, about 2.8 cases per 100,000 person years. And it's apparently increasing in the elderly and immunosuppressed.
Yes, that's an interesting trend. Traditionally thought of as affecting younger adults, but we need to be aware of it in older or immunocompromised groups too.
And the figures for prosthetic joint infections are quite sobering, 1.5 to 2.5% for primary replacements.
Which is still significant.
But up to 20% for revision surgeries.
Yeah, that's a huge jump. Revision surgery is inherently riskier for infection. Scar tissue, altered anatomy, longer operating times.
Yeah.
It all adds up.
And the overall UK incidence is estimated at around 4 to 10 cases per 100,000 people per year.
So, not incredibly common, but common enough that you need to be able to recognize it.
Definitely. So how does it typically present clinically? Your notes break it down into joint and systemic symptoms.
Right. The joint itself is usually the main focus. Patients often describe severe, excruciating pain, often rapid onset.
Along with the obvious signs, swelling, warmth over the joint, redness sometimes.
Yep. And significantly limited range of motion, both active and passive movement, is painful. The joint will be very tender if you palpate it.
And systemically. What else might you see?
Often, patients will have a fever, maybe chills, and just feel generally unwell malaise.
But, and this seems important, the absence of fever doesn't rule it out.
Absolutely not, especially, again, in elderly or immunosuppressed patients, or sometimes if the infection is very localized early on, you can't rely on fever being present.
Okay. Usually affects just one joint monoarthritis.
That's the classic presentation, yes. But polyarticular involvement, multiple joints, is possible. It happens.
And if bacteria are in the bloodstream bacteremia, that can make the systemic symptoms worse?
Yes, bacteremia often correlates with more severe sepsis symptoms, higher fevers, more pronounced systemic upset.
Now, your notes mentioned something really interesting, atypical presentations depending on the joint.
Ah, yes. Important not to get caught out. For example, an infection in the sternoclavicular joint, where the collarbone meets the breastbone, can present as chest wall pain.
Which you might mistake for something else entirely.
Exactly. or sacroiliac joint infection that can cause pain in the buttock, hip, or even down the thigh, mimicking sciatica sometimes.
So you need to think about septic arthritis even with pain in slightly unusual locations.
You do, especially if the other signs like fever or risk factors are present.
What about in children? Your notes say diagnosis can be trickier.
It can be. Localizing signs might be subtle. Often it presents more generally fever, maybe irritability, joint pain, and crucially a reluctance to bear weight or move the affected limb. Pseudoparalysis.
And the hip and knee are most common in kids.
Yes, those are the top sites in the pediatric population. High index of suspicion is vital in children.
And just quickly back to prosthetic joints, the key is suspicion with recurrent pain, even without classic signs.
Absolutely. Any new or worsening pain around a prosthesis, even if there's no obvious swelling or fever, needs investigation for infection. Later signs might include the implant feeling loose or a sinus tract developing like a channel draining fluid.
Okay, so we suspect it. How do we confirm the diagnosis? Investigations. What's the absolute key test?
Synovial fluid analysis, that's the gold standard. You have to aspirate the fluid from the affected joint.
And ideally before starting antibiotics.
Crucial. Antibiotics can quickly sterilize the fluid, making it much harder to grow the organism in culture. Get the sample first if at all possible.
Then what do you do with the fluid once you've got it?
Send it for several things. Gram stain gives you a rapid clue about bacteria type.
Mm-hmm.
Cell count, specifically the white blood cell count and differential, a high count, especially neutrophils, strongly suggests infection. Crystal microscopy to rule out gout or pseudogout. And most importantly, culture and sensitivity to identify the exact bug and what antibiotics will kill it.
Right. So joint fluid is king. What else? Blood cultures?
Yes, definitely take blood cultures. At least 2 sets from different sites. Helpful to see if the infection has spread into the bloodstream, and sometimes they grow the organism even if the joint fluid culture is negative.
Basic blood tests, too. FBC, inflammatory markers.
Standard practice. Full blood count might show a raised white cell count. Inflammatory markers like ESR and CRP will usually be elevated. They're not specific, but they support the picture of infection and inflammation, and they're really useful for monitoring response to treatment. If they start coming down, that's a good sign.
Okay. And what about imaging? Do x-rays help?
Plain x-rays are often normal early on. They're more useful for showing late signs, like joint space narrowing, erosions, or bone destruction, or to rule out other things like fractures.
What about ultrasound?
Ultrasound is really useful. It can detect joint effusions much earlier than an x-ray, even small ones. And critically, it can guide the needle aspiration, especially for deeper joints like the hip. Makes it safer and more likely to get a sample.
And CT or MRI?
They're more sensitive for looking at the surrounding soft tissues and bone. Usually reserved for more complex cases if you suspect an abscess or osteomyelitis bone infection, or if diagnosis is uncertain, or maybe for planning surgery, not usually first line for uncomplicated cases.
And for those prosthetic joints, again, imaging plus aspiration or even biopsy during surgery.
Yes, diagnosing prosthetic joint infection often relies heavily on imaging to look for loosening or fluid collections, combined with getting samples, either fluid via aspiration or tissue samples taken during surgery for detailed microbiological analysis.
Got it. Okay, let's move on to management in the UK. Your notes stress it's a combined approach, medical and surgical.
That's right. You need both in most cases.
And the absolute priority is prompt empirical antibiotics, even before you know the exact bug.
Absolutely. Don't wait for culture results if you have a strong clinical suspicion. Start broad-spectrum intravenous antibiotics immediately after taking culture's blood and synovial fluid.
And the choice needs to cover the likely suspects. Staph aureus, strep.
Exactly. You need good cover for gram-positives, particularly Staph aureus, including potentially MSRA depending on local rates and patient risk factors. And also consider gram-negatives or gonococcus depending on the patient profile. Microbiology advice is really valuable here.
Your notes give some specific UK regimens. Flucloxacillin is mentioned. Or clindamycin if penicillin allergic.
Yes, flucloxacillin is often first line for suspected staph strep. Clindamycin, or vancomycin, are alternatives for penicillin allergy or suspected MRSA. Vancomycin or teicoplanin cover MRSA.
And for suspected gonococcal or gram-negatives, cefotaxime or ceftriaxone.
Correct. Those third-generation cephalosporins provide good cover there. The key is starting empirically based on the likely source and patient, then refining the choice once culture and sensitivity results are back.
Treatment starts 3V, then maybe switch to oral later. How long does it usually go on for?
Typically, a total course of 4 to 6 weeks is needed. The IV component might be for, say, 1 to 2 weeks, or maybe longer, like 3 to 4 weeks, depending on severity and response, before switching to appropriate oral antibiotics to complete the course. So quite a long duration.
Right. And the other key part of management is joint drainage.
Yes, essential. You need to get that infected fluid out, often done initially by needle aspiration, percutaneous aspiration. This might need to be repeated daily initially until the fluid stops accumulating significantly.
And if that's not enough, or the joint is hard to access,
Then you might need ultrasound-guided aspiration, or sometimes surgical drainage is required. That could be arthroscopic washout keyhole surgery to flush the joint out, or sometimes an open operation arthrotomy for a full cleanout, especially if there's thick pus or debris.
why is drainage so important alongside the antibiotics?
Well, it removes the bulk of the bacteria and the inflammatory cells and enzymes that are causing damage. It reduces pressure in the joint, which helps with pain. And it probably helps the antibiotics penetrate better into the remaining tissues.
Okay. And what about resting the joint? Splinting.
Yes, initially, splinting the joint in a position of function helps to control pain and inflammation. But you don't want to keep it immobilized for too long,
Why not?
because prolonged immobilization leads to stiffness, muscle wasting, and long-term functional loss. So, as soon as the acute inflammation starts to settle, usually after a few days, you need to start gentle passive, then active range of motion exercises. Early mobilization, guided by physiotherapy, is key.
It's a balance then. Rest initially, then mobilize early.
Exactly that balance.
How does managing infected prosthetic joints differ? Your notes say it depends on timing.
It does. Very early infections, like within the first few weeks after surgery, might sometimes be treated with easy antibiotics, and keeping the prosthesis in place, maybe with surgical debridement and washout, is called DARE, debridement, antibiotics, and implant retention.
But later infections,
Late-onset infections, or early ones that don't respond to DARE, usually require more aggressive surgery. Often involves removing the infected prosthesis entirely. This can be done as a two-stage procedure. Remove the implant, treat with antibiotics for winks, often with a temporary antibiotic-loaded spacer in place, then put a new prosthesis in later. Or sometimes a one-stage exchange where they remove the old one and put a new one in during the same operation. It's complex surgery.
right, definitely more involved. Your notes also mention reevaluating if there's no response to antibiotics after about 5 days.
Yeah, if the patient isn't improving clinically, pain, swelling, fevers aren't settling, inflammatory markers aren't coming down, you need to ask why. Is it the wrong antibiotic? Is there inadequate drainage? Is there a complication like osteomyelitis? Or is the diagnosis actually wrong? Maybe you repeat the joint aspiration.
And the role of corticosteroids is mentioned as unclear.
Yes, there's some research looking into whether adding steroids might reduce inflammation and maybe improve outcomes. But it's controversial because of the theoretical risk of worsening infection. It's not standard practice currently.
Okay, so what's the overall outlook? The prognosis. Your notes give some quite serious figures for mortality, 10–20%.
Unfortunately, yes. Septic arthritis can be fatal, especially in older patients or those with significant comorbidities. The risk depends heavily on the patient's overall health and maybe the specific organism.
And functional outcome varies too. Your notes mention Staph aureus infections might lead to only 45–50% recovery of joint function,
That's a sobering statistic. Staph aureus is particularly destructive to cartilage.
whereas pneumococcal septic arthritis survivors might regain up to 95% function.
Yes, some organisms seem to cause less long-term joint damage, leading to better functional recovery if treated promptly. It highlights how the specific bug can influence the long-term outcome.
And serious complications like amputation or needing the joint fused happen in about a third of cases, more common in older patients or those with prosthetic joints.
Yes, those major complications are unfortunately quite common, especially in those higher risk groups. It really emphasizes the severity of the condition and the importance of early aggressive treatment.
So the absolute key takeaway for prognosis is prompt treatment equals better outcome. Minimize that long-term damage and functional limitation.
That's the crucial message. Time is joint.
Finally, just to round off, the potential complications, we've touched on some, but your notes list them clearly. Joint destruction,
Leading to chronic pain and arthritis,
joint deformities,
affecting function and appearance,
systemic infections, sepsis,
life-threatening if not controlled.
osteomyelitis infections spreading to the bone.
Can be very difficult to eradicate. Requires long courses of antibiotics, sometimes surgery,
And abscess formation in or around the joint.
collections of pus that usually require drainage, all serious potential consequences.
Right. So, what does this all boil down to for you, the listener? We've taken those detailed notes and hopefully unpacked them into something clearer, more digestible.
Yeah. Hopefully a useful revision blast.
You should now have a solid overview, the definition, causes, risks, how it happens, what else it might be, who gets it, how it looks, how we investigate and manage it, the likely outcomes, and those potential complications.
Remember those mnemonics, SIJ for symptoms, a DJ, ship's core S for risk factors. Little hooks to help recall the key points.
Absolutely. Hopefully they stick. This deep dive should give you a really good head start in understanding septic arthritis. Now, for more in-depth revision, practice questions, really nail this down. Where should people go?
Well, PassTheMSRA.com has a great bank of questions specifically tailored for the MSRA exam format. Really good for testing your knowledge.
PassTheMSRA.com. And for more free resources, blogs, tips to support learning.
Check out FreeMSRA.com. Lots of useful stuff there, too.
Excellent. So PassTheMSRA.com for questions, FreeMSRA.com for more free resources. Keep exploring, keep revising, and keep learning.